Yeah, now it is there. So now the voice is there. Please confirm. Hi Varun. Hi Rahul. Okay, so now the voice is there. Okay, so I was just saying, guys, that today is day two of the questionnaires that we have given you yesterday night at 10 p.m. Okay, so I do believe that you have done all the questions of day before yesterday. That was day one of orthopedics, and the video for same is still there on the YouTube channel. You can just go there and you can just watch the video of those 20 questions. And today I'm going to discuss with you. Yeah, yeah, John, thank you, AM. So now today I'll discuss with you the rest of the questions for the day two, the questions which are coming from the remaining trauma part, or maybe the bone tumors, the infection, the joint disorders, the complications, and so on. Okay. Hi, good morning, Pooja. Okay. Good morning, Shahar Bhanu. Okay. So let's start. Okay. We'll just start with this. See, the very first question is a very straightforward one, and I do believe that most of you would have been easily able to answer it, right? A diabetic patient, diabetes, one of the very, very important risk factor we know for any kind of compressive neuropathy, right? The patient is coming up with a complaint of what? Pain, tingling, numbness around the thumb, index, and middle finger. And we know these are territory of what? These are territory of what? The median nerve, isn't it? And median nerve compression at the wrist is very, very common. What do you call that? The carpal tunnel syndrome. And why the patient is having more trouble during the night? Because we are more relaxed, right? We have all the attention towards all our pain points, and that is why the carpal tunnel. Now, one very simple thing I would like to tell you is most of the time I have found the student getting a trouble with the supplies of the hand, the root supplies of the hand. So we know that brachial plexus is made by what all roots? It is C5, C6, C7, C8, and T1, isn't it? Now look at your hand. Look at your hand. This is C5. Okay, the C5 supply, C6 supply, C7 supply, C8 supply, and here goes the supply of the T1, right? Here goes the supply of T1, right? So C5 to T1 is what the brachial plexus is made up of, and from that, the terminal branches, the median nerve, ulnar nerve, radial nerve, they all should be very, very clear to you, and all the clinical tests, which I believe you have learned by heart. If not, please see the video sections or just let me know if you're not able to recall the test of the median nerve. Okay, so this is carpal tunnel syndrome, the distribution area, the one, two, three, and this three and a half. Okay, so three and a half for the median nerve. All right. Second one is a little bigger question, but a very, very conceptual question. 29-year-old female presents to you with difficulty in walking and climbing stairs for last 3 weeks. So not a very old kind of thing, a kind of acute, involvement. Physical examination reveals a waddling gait, right? Waddling means the pelvis is unstable. The pelvis is getting up and down all the time with her trunk swaying from side to side towards a weight bearing limb. So trunk is getting swayed up. When she stands on her right leg, when the lady is standing on the right leg, the pelvis on the left side falls. What are we actually talking about? You all can recall the test I have demonstrated also to you. We have discussed in detail. It is about the Trendelenburg test, right? It is about the Trendelenburg test, right? So what exactly Trendelenburg checks? It checks for the abductor mechanism of the hip. Okay, it checks for the abductor mechanism of the hip, and that is being governed by which muscles? We know that is governed by gluteus medius and the gluteus minimus. And these are supplied by which nerves? These are supplied by the gluteal nerve, the superior gluteal nerve. Okay, so we are checking for basically the Trendelenburg gait or the test basically, which are checking or being controlled by abductor mechanism of the hip. Okay, so this is a very, very important question for your FMG examination, and it has been asked quite a number of times. Now, when you see this third question, 14-year-old boy, age adolescence, weight little overweight, 78 kg, and hypothyroidism, that is endocrinal disorder. We can very well understand from here, okay, endocrinal abnormality. And he develops sudden onset of severe pain. That is, we are talking about a acute case, okay, and tenderness on the left hip area as a result of minor fall. With the minimal fall, what has happened is that there is a pain which has started acute onset, and we know that adolescents with the endocrinal abnormality, right, is most susceptible to get what kind of hip disorder? That would be slip of the capital femoral epiphysis. You remember that this epiphyseal area, the head of the femur, and the rest of the bone, they lose the proper articulation. Okay, that is a greater trochanter we have. So this weakness of the growth plate is the reason why the rest of the bone is being pulled up with minimal impact, right? Slip of the capital femoral epiphysis. Okay, that's very, very important. Please do remember that fracture neck femur will not only have got actually no relation with the hypothyroidism, right? It can have be or it can be a possibility as well. Perthes disease is a problem which happens at the age usually between the 4 to 8 years, right? Pediatric population. Hip dislocation, it is again a possibility, but that has got no relation again with the endocrinal abnormality. So when they are giving you some clue in the question, you should be vigilant enough to understand that. All right. Next one, 4-week-old baby presents with the deformity as shown here. What will be the next best management? So we are talking about a case of what you all can appreciate that this is a case of bilaterally the feet are deviated like this. Okay, that is CTV. So what should be done? Manipulation by mother. Yes, it has to be done whenever possible, but the best treatment always has to be surgery. And we know that how or what should be the sequence of correction. We learned in our notes as well that sequence of correction has to be adduction, the cavus, adduction, varus, and equinus. And in short, how do we learn it? This is CAVE. So cave has to be the sequence. Cave has to be the sequence all the time whenever you are trying to correct the CTV, right? What is the technique called as? The technique is called as the Ponseti technique, right? So we correct the CTV foot by Ponseti technique. All right. So please remember CTV, the sequence of correction has to be cave. Okay. And if we don't follow cave, there might be a possibility that the foot may break down and the foot instead of being like this now goes like this. Okay. Like now it goes like this. So what exactly is that? That is called as a complication which happens here. It is called as rocker bottom foot, right? That is called as the rocker bottom foot. Okay. That would be rocker bottom foot. All right. Infection questions I have given you the main hallmark for chronic osteomyelitis. By definition, we said any infection which has been there in the bone for how long? More than 6 weeks is a case of chronic infection, chronic osteomyelitis. But the sequestrum, which is a dead body, the dead bone basically inside the infected area. So it is a dead bone, right? That is a dead bone which is surrounded by a lot of granulation tissue, the abscess. Okay. What exactly is a cloaca? Cloaca is an opening. Where does it happen? In involucrum. So cloaca will be a opening in the involucrum. And what is the involucrum? Involucrum is a reactive new bone, right? So discharging sinus will come once these three are already there. Then only the discharging sinus comes. Sequestrum, lot of granulation tissue, new bone, and rupture of that new bone is cloaca. And once the abscess comes out of cloaca, then it comes out of the soft tissue. So discharging sinus, it what you see onto the skin, the superficial surface basically. Okay, so it has to be the sequestrum all the time. Then only we call it a chronic osteomyelitis. Now, this is one catchy question, very important one very catchy question. Most specific test for the lab diagnosis of osteomyelitis. See, guys, we understood two things. One is the specific one. Specific one means the one which confirms, yes, there is a problem, right? The one which confirms, yes, there is a problem. Specific one is to put a needle inside the infected area. Specific one is to put a needle inside the infected area. And if you're able to aspirate the abscess collection over there, we know it's infection. By chance in your exam they change it to what is the most sensitive, what is the most sensitive investigation. Sensitive investigation means the one which shows you the changes if an infection is happening. The sensitive ones are always and always the MRI, because it shows marrow edema, which the MRI can show within first 24 hours of the infection. So sensitive one, the investigation which shows you the changes. Specific one, which confirms yes there is infection. This specific one we can also call it as what? The gold standard to confirm that there is infection. So read the exam question very carefully, specific or sensitive, right? Read it very carefully, the aspiration and culture. Okay. Earliest feature of TB. Now that's a very classical question to be asked. I always tell you and show you one very classical picture. In our notes also we have drawn that whenever TB occurs in vertebra, right? There is a disc in between here, and then we have another vertebra here. Okay, and we know that all the three, they are having a common blood supply, right? Because of their developmental pattern. So when they have the common blood supply, we know most commonest route of spread of infection is what? Hematogenous. So all the three areas will be getting destroyed at a time, right? And that will lead to what? Decrease in the joint space. Which space? We are talking about the intervertebral disc space. So whenever there is a patient who has got some pathology which is decreasing the intervertebral disc space, we know probably it is infection. And most commonest infection of the spine, it is tuberculosis, right? Once the infection is there, they are going to destroy this area. Gradually the posture of patient will be bending like this, and patient bends in front like that, and that is called as what? Kyphosis, deformity, they all will be happening, but not this one. So decrease or loss of the intervertebral disc space is a classical picture of TB hip, right? Septic arthritis of hip in infant, what do we call it? It is Tom Smith arthritis. Now, what exactly is that? Infancy, we know, is less than 1 year. And how this is different from the tuberculosis, you remember? In the hip joint of pediatric age group, you know that this is how the hip will be because the growth plate is still there and the joint is still developing. So this is the greater trochanter. So when there is an infection of the hip area, this is the triradiate cartilage we have, acetabulum. So please remember that acetabulum, this one, is the most commonest site where the infection of tuberculosis goes, most common. But this site number two is the most commonest infection where the septic arthritis happens. We know that both are infections of the joints only, right? Both are infection of the joint only. So they will be involving first the synovium all around, correct? From the synovium, the infection can go to the acetabulum, it can go to the head of femur. So in most of the cases, tuberculosis first destroys the acetabulum. And in the septic arthritis, the first area to get involved is head of femur. So again, the infections are different. Tuberculosis most often destroys acetabulum. Normal organisms often destroys head of femur first. So again, read the question carefully. If they ask you what is the most commonest site for septic arthritis, then it has to be the epiphysis, proximal epiphysis. That is this one, number two. If they ask what is the most commonest site of tuberculosis in the hip, it has to be acetabulum, right? So both the questions should be very, very clear to you. Identify this tumor. In the tumor, what was the basic principle to go ahead with the tumor part? So we know that in tumor, we have to go in three steps. The first thing to be always, always seen is the location of the lesion, whether it is epiphyseal, whether it is metaphyseal, whether it is diaphyseal. Second thing to be seen is its nature, whether the lesion is benign aggressive, or it is purely aggressive, that is malignant. And then third would be if you are able to see any special feature. Can you see any special feature? So let's see the lesion here. Look at this. The lesion here is located where this is epiphyseal area, this is metaphyseal area. So lesion here is where it is at metaphyseal area. Correct? Metaphyseal area. Second, what is the nature? See, cortices are still maintained. Cortices are still maintained, a very thin layer though, but yes, it is maintained, it is not yet breached, and no periostal response. So seems like a benign picture. Anything special you see? There are multiple septations inside, if you can appreciate that. Now, if that is special feature, what do we call that? Septations, expensile bone lesion. What is that a feature of? Almost similar to something called soap bubble, right? Where do we see that? It has to be in aneurysmal bone cyst. Now that soap bubble, if you look at the epiphyseal area, if you're able to see any soap bubble at epiphyseal area, then it has to be giant cell tumor, right? But you know very well that giant cell tumor will be seen in adults. Giant cell tumor will be seen in adults, okay? And here we can have, or we can see actually the growth plate. I can see the growth plate over there. So epiphyseal area, metaphyseal area in between growth plates. So ABC is usually seen in children's. GCT is seen in second to fourth decade, that is adults, right? So never break the sequence as we have always discussed to identify any tumor. This is the sequence, okay? Never change the sequence. First thing to be seen is location, nature, then third is special feature. Always and always like that only. There is no way in which you have to change it. All right. Then we have typical feature of unicameral bone cyst. When you see a piece of bone into a very, very big lytic area, same thing, metaphyseal area, benign lesion, and with a piece of bone inside the lesion or the cavity, then it is called as fallen fragment sign, right? Which is typical of unicameral bone cyst. How to differentiate an aneurysmal one from the unicameral? Unicameral will have a piece of bone inside, ABC will have septations, expensile bone lesion, right? Most likely diagnosis, let's go ahead with the same plan. We have a epiphyseal lesion, which is right now benign because I can see the all the boundaries here, right? And epiphyseal lesion, benign lesion in a skeletally mature patient. If it is skeletally mature because I don't see any growth plate here, then it has to be what? The giant cell tumor. Then it has to be what? The giant cell tumor. But if it would have been epiphyseal and benign or benign aggressive, but the patient would have been skeletally immature, right? If I would have been watching some growth plate over here like this, right? I would have simply called it what lesion? It should have been chondroblastoma. That would have been chondroblastoma. So cartilage will be in pediatric age group. That is why skeletally immature patient. GCT in skeletally mature patient. So epiphyseal lesions, what I've just told you here, epiphyseal lesions, when you talk about them, we have got two. One is giant cell tumor, one is chondroblastoma. How to make a differentiation in them? It will be a X-ray of a adult. This will be an X-ray of a pediatric age group where the growth plate will be usually visible, right? Where the growth plate will be actually usually visible, right? That is a differentiation. So location plays the most important role when you are trying to figure out a lesion. All right. So tumors, please go through that and please go through that chart we have drawn, the image we have drawn of the bone, and I have to identify, like we tried to identify the lesions. All right. Next one, a computer operator presenting with severe pain around the base of the thumb. See, at the base of the thumb, there are only two to three things which are very, very common. Okay. And pain increases on slightest movement while pressing the keyboard. So when they're trying to press the keyboard or using thumb, it is painful. Okay. Sugar levels, HbA1c levels a little on the higher side. What are we talking about? So we are talking about the condition where the tendons at the base of the thumb is inflamed. What do you call that condition? It is called as Decurvain's tenosynovitis. It is called as the Decurvain's tenosynovitis, right? Remember, abductor pollicis longus and extensor pollicis brevis, where are they? This first tendon that you see at the base of your thumb, making the boundary of anatomical snuff box, right? The first tendon, you just stretch your thumb, and the first tendon that you see on the back is actually this one. If you can see this, this one is APL and EPB, right? The base of the thumb, that is called as Decurvain's tenosynovitis. First movement lost in adhesive capsulitis when there is a capsule getting inflamed, leading to adhesions in the shoulder. The first one to get involved is always internal rotation. The patient won't be able to keep the hand on lower back, right? The patient won't be able to keep the hand on the lower back. That is what is lost. And we have understood the logical reason also with that. Head of humerus, glenoid, capsule, and next to that is subscap. That's why it is getting involved. Finkelstein test, the same question we have just discussed, APL and EPV. The Finkelstein test and the other test I can tell you is ICOF. Okay, the ICOF test and the Finkelstein test are the ones which are done for the Decurvain. So ICOF and Finkelstein is what? Ask the patient to keep the thumb in the fist. Ask the patient to keep the thumb in the fist and go for ulnar deviation. Now, if there is an inflammation at base of the thumb, it will not be possible, right? It won't be possible. That is ICOF. And Finkelstein is simple. Hold the thumb and just pull it, right? That is Finkelstein and ICOF for Decurvains. Right. Number 15 is a patient post RTA is being brought in casualty, right? Trauma. RM on duty observed that he's having fracture of both bone legs, and which of the following situation makes it an emergency to call the resident orthopedics on duty? Now you know that open fracture is again emergency. Pain on passive movement of ankle. What is it telling you? It is telling you the pressure is building up in the fascia in the leg, and it is called compartment syndrome. That's called as compartment syndrome. No palpable dorsalis pedis. That is again a emergency, definitely, right? It might be compressed somewhere. Comminuted fracture, it is again emergency, but the one with the irreversible changes is always a compartment syndrome. So just call him right now, sir. There is a patient who is not having, or maybe I can't feel the pulse, that's fine, but you have to come soon. But then there is another one where there is a lot of pain on the passive stretch. That means the pressure is already raised, and he right now requires or might be requiring immediate fasciotomy. So we are talking about compartment syndrome. So this is the first sign that we see whenever there is a compartment syndrome. So be very, very vigilant with that, right? Compartment is a very important complication. Another very important complication, a repeated question of your multiple exams. 28-year-old male who is admitted in ortho ward for fracture femur, long bone. He sustained today and is proposed for surgery like kind of after third day. On second day, he is having discomfort and difficulty in breathing. That means respiratory system is getting involved, right? On examination, SpO2 is also decreased. That means the decrease in the pressure of oxygen. We are talking about what? We talk about the GERDS criteria, right? We talk about the GERDS criteria. Respiratory system, the GERDS criteria. Now, what are we talking about? This is simply fat embolism syndrome, which happens after the fracture of the long bones, the shaft of femur, shaft of tibia, right? And GERDS criteria, where the fat embolus gets into the circulation within 24 to 72 hours of the injury, right? So this is fat embolus. Okay, now another one. This is from your joints. A lady having flexion at the PIP. So proximal IP joint and distal IP joint. Okay, proximal IP joint and distal IP joint. Flexion at PIP and hyperextension at DIP. What are we talking about? This is the botonier deformity. That's what we call botonier deformity. Swan neck will be how? Swan neck is when the DIP is having a flexion, okay, and the proximal IP joint is having hyperextension. So when the last joint is having a flexion, that is this one, is what you call swan neck. Where do we see these all deformities? The windswept deformities of toes, the Z deformities of the wrist. Where have we talked about all of them? These all are a feature of classical case of rheumatoid arthritis, right? These are all the classical case of rheumatoid arthritis, right? So botanier, yeah, botanier, swan neck, windswept, and Z deformity. All right. Okay. So in OA, what is the first joint to be affected? It is always knee. Why? Because OA is a problem of cartilage, and the biggest cartilage that we have is in the knee only. On the other hand, this rheumatoid that we have just said, it is a problem basically related to synovium, which secondarily will destroy the cartilages, right? So RA, that is the reason why it affects the wrist most often. Knee is most commonly involved in OA because the cartilage, the meniscus is over there. Okay. Next one, 9-year-old male with pain in left hip and limping. So we have a little kid with us now, 9 years, and there is history of fall in the park 1 month back, a month back, old trauma, right? Not a very acute one. Please remember, SCFE had a acute trauma and the hip got slipped. The epi and the meta got a slip. On examination, there is restricted abduction and internal rotation. Abduction internal rotation is restricted. That means how the patient is coming adducted and externally rotated. And you know, this kind of mismatch is only seen in two conditions. What are those? One is Perthes and other one is SCFE. There are two conditions where we see that. Perthes is a problem of 4 to 8 years. SCFE is a problem of adolescent, right? 4 to 8 years or 10 to 15 years, right? So this is what we are talking about, Perthes disease. Okay, the osteochondritis of the femoral head. I do believe you have the list of all the other osteochondritis as well, of the scaphoid, of the capitulum, of the vertebra. So this is osteochondritis of head of the femur, the process which can lead to avian of the head. And this one, I'm sure you all can easily recognize it. It is what you call as the Thomas splint, designed by H.O. Thomas, right? Designed by H.O. Thomas, the fracture shaft of the femur. The H.O. Thomas designed it, and it was initially designed to support the tuberculosis of the knee, to give rest to it while traveling or while, like, bending. It should not be getting bent. Later on, now we have started using it for stabilizing the fracture shaft of the femur as a part of some management plan, or maybe while transportation of the patient. Okay, so my recommendation would be that all of you must have that file with you, the PDF, the instruments and implants, the splints and tractions, and go through them once before you go to the exam. I'll be sharing that file with you in your Telegram group also. And the link of Telegram, I'm sure you all might be there on the Telegram group with us. Okay. And that is all from orthopedic side. But I do believe, guys, that you all are solving all the questions that we're giving you every day, per day, for different subjects. So today, this orthopedic part was actually complete yesterday only. And from today, we are starting with the surgical part. So Sakshi madam has already shared the questions with you, and in the Telegram group also, I'll be posting the screenshot of the same. Start doing the schedule, start following the schedule, what we are giving you per day. And if you don't have your own schedule, and if you are going good with your own schedule, and how to check that if you're going good or no, that you have to assess yourself by giving the GTs or the cumulative test. Now, whatever test you are going, if in those tests, whatever subjects you have already completed, if your scoring is good over there, then definitely you are on the track. And if the scoring system is bad, if you're not able to perform well, that means something is wrong with the knowledge or the concept or the memory or the facts of that subject. Then we have to work upon that, right? So please follow the schedule what we have given to you, and we'll make sure that we are going to give you the schedule till the last day of your exam, and you're going to revise it well. Okay, so this is all targeting your June session exam, and we will make sure that whatever schedule we are giving you, you follow. Once you follow that, your all the subjects that you're reading regularly are revised very, very properly. All right. So that is all from my side. And if you want anything from us, from other, like, academic things, feel free to post it on the Telegram group, and we'll be more than happy do whatever best we can. Right. So aim is just one, that we have to target minimum 200 marks this time in the FMG exam. Right. That has to be the aim. Don't think of just passing it. We have to make sure that we are crossing 200. Okay, so that should be the aim. There is no if or but in that. Okay, and we all have to prepare together for that exam. All right, so that is all from my side. Thank you so much for joining in.